Good morning, and thank you for joining us this morning for Winship Grand Rounds. If you're an Emory University or healthcare employee and would like to receive CME credit for attending today, the login information can be found in the chat feature at the bottom of your screen. If you have any issues with this webinar or the CME login, please send Kadiato Fofana an email or drop a note via the chat feature. This morning, we are pleased to welcome Dr. Kevin Kalinsky. Dr. Kalinsky received his medical degree from the Medical University of South Carolina and a Master in Biostatistics Patient-Oriented Research track from Columbia University Mailman School of Public Health. His training included a residency in medical oncology fellowship at Tufts New England Medical Center, breast cancer research fellowship at Massachusetts General Hospital, and breast cancer advanced oncology fellowship at Memorial Sloan Kettering Cancer Center. Dr. Kalinsky is currently an associate professor in the Department of Hematology and Medical Oncology at Emory University School of Medicine. He also serves as the director of the Glenn Family Breast Center at Winship, where he's tasked with fulfilling the vision to improve breast cancer outcomes by aligning research and education with cancer treatment and prevention. He's a member of the Development and Discovery Therapeutics Research Program at Winship. His research is in new drug development and therapies for patients with early stage and metastatic breast cancer. His work involves the development of clinical trials to assess novel therapeutic agents and breast cancer based on tumor genomics, and he is widely published, including publications in the New England Journal of Medicine. He's funded by several sources, including the NIH, the Breast Cancer Research Foundation. Welcome, Dr. Kalinsky.
Thank you, Dr. Torres. Good morning, everybody. Thank you for joining. This morning, we'll talk about genomic assays in patients with hormone receptor positive HER2 negative breast cancer. And hopefully I will make the case to everybody who's on just that we are moving towards individualization and personalization of therapy. We still have some ways to go, but some of the advances that we've made in this particular subtype of breast cancer is being able to identify who can opt out of chemotherapy and which patients we could just do hormonal therapy alone and save patients the potential toxicity that's associated with chemotherapy. These are my disclosures. In the talk, I thought we would go broad and then we will go deep and talk through some of the data from various randomized trials and then go broad again. And whenever we're making a decision about systemic therapy for patients with breast cancer, and for any cancer for that matter, there is always this balance between risks and benefits. And in the early stage breast cancer setting, we are always balancing the prognostic and predictive features, as well as the patient's age, organ function, and comorbidities when deciding what kind of adjuvant systemic therapy we should be considering. This slide just demonstrates how we've been utilizing biomarkers in patients with early stage breast cancer. And of course, in the 1970s, there was the determination of ER and PR per protein expression, and then HER2, which was prognostic and then ultimately predictive once we started to incorporate HER2 targeted therapies like trastuzumab. And then in the early 2000s, there was gene expression, and we're going to spend a lot of time talking about some of these assays, in particular the Oncotype DX assay in MammaPrint, and we'll spend just a moment talking about the breast cancer index. And then more recently, there's been focus on mutational profiling. Whenever we're thinking about biomarker development, I think this slide helps frame what we should be considering. There's analytic validity, meaning is the assay reliable? Is it reproducible? It's clinical validity, meaning does it associate with clinical outcome? And then clinical utility, meaning does the treatment change based upon the specific results of an assay? And do patients benefit from a change as determined by the assay? So we can ask ourselves, which patients with hormone receptor positive HER2 negative breast cancer benefit from adjuvant chemotherapy? And as I mentioned, a good amount of this talk is going to be discussing the 21 gene recurrence score assay. 16 of of these genes are non-reference genes, and then 5 of them are reference genes. And these this assay was originally developed in prospective retrospective studies. For instance, from the prognostic perspective, this assay was validated in an NSABP study that was published in the New England Journal of Medicine, where you can see on the left in the Kaplan-Meier curve that the assay could discriminate low risk, intermediate risk, and high risk based upon freedom from distant recurrence. Also, in a multivariate analysis, the recurrence score demonstrated here at the bottom of the table remained an independent prognostic factor for risk, even when you're incorporating other clinical features. And then this assay was prospectively validated for prediction in another NSABP study. And what you're seeing here is that the patients who had lower intermediate scores, in this particular analysis, intermediate was defined from 18 to 30. You can see it was those patients who had high score, as demonstrated in this red bar, were really the patients, including in this Kaplan-Meier curve, who benefited from chemotherapy. Those patients who received chemotherapy are demonstrated in blue, and those patients who received tamoxifen alone are demonstrated in red. Those were the prospective retrospective studies that served as the rationale for conducting the TAILOR-X trial. And this was a game changer of a study in which patients with hormone receptor positive HER2 negative breast cancer that was node negative, if they had a recurrence score which was defined as intermediate, meaning in this study it was 11 to 25, these patients were randomized to endocrine therapy alone versus chemotherapy followed by endocrine therapy. And part of the rationale for having this recurrence score being 11 to 25 is that this was really the question, this was the group for which we were hoping to ask the question of, can patients opt out of chemotherapy? And the majority of patients fall into this category. Those patients who have a low score received endocrine therapy alone, and those patients who received, who had a score of 26 or greater were assigned to chemotherapy followed by endocrine therapy. And these were the results that were initially presented at ASCO in 2018 and published in the New England Journal of Medicine, where you can look at 9-year event rates and see that those patients who had a low recurrence score did very well. Those patients who had a high recurrence score, meaning 26 or greater, despite receiving chemotherapy, still had a distant recurrence of 13%. And this study was reiterating that the recurrence score can be prognostic. And if you look at the overall results from that group of 11 to 25, again, asking that question of whether patients needed chemotherapy or not, one can see across various endpoints, including invasive disease-free survival, overall survival, distant relapse-free interval. In the overall cohort, there was really no benefit for receiving chemotherapy for these patients. But then as part of this analysis, they performed an exploratory analysis looking at age. And they saw a statistically significant interaction based upon age, meaning that those women who were less than 50, that there was a difference compared to those who were older. And the thinking being that age is a surrogate for menopausal status. And we'll go back to that group in just a moment. For the patients who had a recurrence score greater than 25, these were some data that were subsequently published in JAMA Oncology, where if you look at the white bar, these are the patients, what the expected rates would be if they received endocrine therapy alone. And in blue is what the actual rates. Again, all of these patients in TAILOR-X were assigned to receive chemotherapy followed by endocrine therapy. And one can see that those patients did better than what would have been anticipated if they received endocrine therapy alone, as highlighted in white. So I said we would go back and talk about those patients who were less than 50 years of age or less. And as part of this study, the TAILOR-X group had wanted to explore the role for clinical risk. And what they saw is that it's not just the score itself, but it's actually informative to have clinical risk as well. And you can see the definition of low clinical risk as described below. And the definition of clinical risk here is similar to the definition of clinical risk that was utilized in the MINDAC study with the 70 gene mammoprint score, which we'll talk about in just a couple moments. But you can see that patients who had recurrence scores 16 to 20, if you had a low clinical risk, you didn't really seem to benefit from getting chemotherapy. It was those patients who had high clinical risk in recurrence scores 16 to 20 who seemed to have a delta for the addition of chemotherapy in terms of benefit. Of course, these are small cohorts, and you can see that the standard error is wide. For those patients, again, hormone receptor positive, HER2 negative, node negative that were in TAILORx, for those patients who had low clinical risk as well as high clinical risk, didn't seem to matter, but those patients seemed to benefit from chemotherapy. Those data served as this rationale for doing this computational modeling, which included data from TAILORx, as well as some other studies like the NSVP studies that I mentioned previously that served as the rationale for the prognostic and predictive utility for the 21 gene assay in this subgroup of patients. And what they saw in this modeling is, again, clinical risk is important. So if you have a patient, for instance, who has a 1.5 centimeter tumor, and if you go from grade 1, 2, or 3, and once you get to grade 3, that is changes from the patient being clinical low risk to clinical high risk, you can see that these curves change and the risk changes. And the same holds true for a patient who has a grade 2 tumor and the tumor size increases. You can see that as you go from 1.5 centimeters through to 3 centimeters, the slope of the curve changes. And they also looked at prediction, and what they saw was that the higher your recurrence score, the greater your likelihood would be for the benefit for the addition of chemotherapy. So, for instance, if you have recurrence score of 13, your potential benefit is higher from chemotherapy for recurrence score is 28, right? So we knew that. The other thing that's demonstrated here is just, for instance, other clinical and pathologic features. And what's demonstrated in these bars are grade. So for instance, if your recurrence score is 23 and you have a grade 3 tumor, your potential benefit from chemotherapy is higher compared to if your recurrence score is 23 and you have a grade 1 tumor. And the reason that this is important is in our clinic on the Genomic Health and now Exact Sciences website, there's a tool that's called RSClin based upon the modeling that I just showed you, where you can put in a score, put in the tumor size, put in the grade, the type of hormonal therapy that you're considering, and the age at surgery. And you can then have an output of, well, what is the individualized distant recurrence risk at 10 years? And also, what is the absolute chemotherapy benefit? Right, so we can sit in, when we have this conversation with the patient, it's not just us utilizing the recurrence score, but we can actually say to a patient, well, this is what your risk is at 10 years, and this is what your benefit of chemotherapy is. And this is really, as I mentioned, this movement to precision medicine that we see for patients with early stage breast cancer. There's some caveats to this. This only applies to patients with node-negative breast cancer. Some of the subgroups, including very young women, including women that are 35 years or less, is really a small population of what's represented in this modeling. And they validated the prognostic significance when developing this model, but there was no validation set for prediction. The other thing I want to mention before talking about node-positive breast cancer is just some data that was done looking at race and ethnicity. And there have been some previous data suggesting that from some other groups that the oncotype score could be different in patients who are Black compared to other races and ethnicities, and that it seemed to be driven by proliferation. And what was seen in this assay, in this analysis, which this analysis is from TaylorX, is that patients who were reported as Black, as demonstrated in purple, despite being less than 5% of the population, had worse outcomes from distant relapse free interval, as well as overall survival. So the next question, we talked about node negative disease. What about patients with node positive breast cancer? And we know that patients who have 1 to 3 nodes, for instance, can do worse. The presence or absence of nodal status and historical data remains a important prognostic feature. There was retrospective data from a SWOG study called 8814, and this was a study that was a very important study which demonstrated the potential benefit for chemotherapy. And this study included patients who were postmenopausal. And this study looked at chemotherapy with Cytoxan and Adriamycin and 5-FU. And they prospectively, this was prospective randomized study, and then they retrospectively went back and looked at, well, can recurrence score discriminate risk? And they did see that those patients who had high risk oncotype, in this study, recurrence score greater than 30, that those really seem to be the patients who benefited from chemotherapy, as demonstrated in blue, as opposed to those who received tamoxifen alone. And that's different sort of curves than what we're seeing for patients with lower intermediate recurrence scores. I'll also say that there had been data from the Harvard group, which looked at node negative and node positive patients. And you can see, again, and this is broken out by recurrence score, you can see that the risk is different for those patients with node negative and node positive breast cancer. And even though some of these numbers are small, this did suggest that maybe the values of recurrence score, especially in young women, in terms of leading to the benefit of chemotherapy, was different in node positive compared to node negative tumors. And if you look at the multivariable analysis, you can see that recurrence score remained an independent prognostic feature in this particular study. So there was a study called the Responder Study, which we reported at San Antonio in 2020 for patients. This included patients with hormone receptor positive, HER2 negative breast cancer, similar to the TaylorX study, but this study is different in that this included patients with 1 to 3 nodes involved. And all patients must have been able to receive quote unquote modern systemic chemotherapy with a taxane and or an anthracycline. And in this study, if the recurrence score was greater than 25, you were off study and recommended to receive chemotherapy followed by endocrine therapy. But if your recurrence score was 0 to 25, these were the patients who were randomized in a 1-to-1 fashion to chemotherapy followed by endocrine therapy versus endocrine therapy alone. And the total sample size was 5,000 patients. And you can see the stratification factors are listed here for recurrence score, menopausal status, and axillary surgery. So we had pre-specified menopausal status as a factor that we were going to look at. This is demonstrating the distribution of the recurrence score by menopausal status, premenopausal here, postmenopausal here. You can see the median is about the same, but the curves look just a little bit different. We subsequently reported these data in the New England Journal of Medicine in December. And the take home from this study is that there was a difference between the patients who were postmenopausal and premenopausal. The postmenopausal cohort, which were represented by about 2/3 of patients in Responder, if you look at the 5-year invasive disease-free survival, there was no difference. These lines fully superimpose in terms of invasive disease-free survival, which was the primary endpoint. Premenopausal women, however, if you look at those patients who received chemotherapy, were randomized to chemotherapy as demonstrated in blue, there was a hazard ratio of 0.53, and this was statistically significant, and an absolute difference at 5 years of about 5%. And this curve is in the supplement of the paper where you look at that premenopausal group, you can see that there are patients who have recurrence score 0 to 10 who seem to be benefiting from chemotherapy, again, demonstrated in blue. These are exploratory analyses. You can see that those curves come a little bit closer together when you get to 11 to 15. And then when you start to get out to 16 to 20, those curves really do start to separate. And when you look at age, instead of the patients who are identified as being premenopausal, if you specifically just look at age, you can see that the curves look similar, even though the slope of this curve is a little bit different. So then we also looked at, well, were there any postmenopausal patients who seemed to benefit from the addition of chemotherapy? When you look at the forest plot, all of these cross one, and there was really no subgroups who seemed to benefit. And if you look at the premenopausal subgroup and look at the interaction p-values for all of these different clinical and pathologic features, we couldn't really identify a group of premenopausal women who did not benefit from chemotherapy. Then at San Antonio 2021, we updated these analyses and also looked at the most narrow of definitions, distant relapse-free interval, and the data held up, meaning postmenopausal women, no chemotherapy benefit. When we look at 5-year distant relapse-free interval for the premenopausal cohort, which is defined of time from randomization to first invasive distant recurrence or death from breast cancer, there continues to be a benefit in the premenopausal cohort. One of the questions that has come up is, what about patients with micrometastasis? So, when I say 1 to 3 nodes involved, I was referencing macrometastasis, where it's 2 millimeters or greater in the lymph node. But what about tumors that involve the lymph node but are micrometastasis? And the study opened in 2011 and then 2014. We amended the protocol to specifically exclude patients with micrometastasis only. You can see that in premenopausal women, 206 of those happened to have micrometastasis only, so pre-amendment. And this is an exploratory analysis, but you can see that numerically speaking, the benefit of chemotherapy remained about the same with a hazard ratio of 0.44. But also, just to reiterate the point, these were very few patients and only 22 invasive disease-free survival events. And if you look at the patients in this analysis who had 1 to 3 macromets, the 5-year IDFS absolute chemotherapy benefit is 4.8%. Again, adjusted hazard ratio being about 0.6, that does not cross 1. And then we also looked at whether patients who were premenopausal were still having regular periods or not. Because there have been other data from other NSBP studies that had suggested that if you stop having periods, that's prognostically important, that you tend to do better. And we saw in the patients who received endocrine therapy alone, or those patients who were also randomized to chemotherapy followed by endocrine therapy, that if you stopped having regular periods, as demonstrated in blue, you did better. You also note that the rate of no longer having periods was higher if you were randomized to receive chemotherapy followed by endocrine therapy. But regardless of which arm, you seem to do better if you stopped having periods. It's also worth noting that in this cohort, only about 16% of patients overall underwent ovarian function suppression. So very few patients, and that's a number that is similar across other randomized studies, and actually in TAILOR-X, it was a little bit lower. So when we look at responder and the conclusions, postmenopausal patients with 1 to 3 positive nodes and recurrence score 0 to 25 can likely safely forgo adjuvant chemotherapy without compromising invasive disease-free survival. And this is a really important finding because it saves tens of thousands of women the time, expense, and associated toxicities that we can see with chemotherapy. Premenopausal women, however, likely still benefit from chemotherapy. There are some limitations. We're still awaiting events. Actually, we're still awaiting about 1/3 of events at this point. And the remaining question from this study is whether that chemotherapy benefit that we see in premenopausal women, is that exclusively due to amenorrhea, or is there an innate biology difference between premenopausal and postmenopausal women? And is there a direct chemotherapy benefit that's outside of the amenorrhea, which may be driving the benefit that we're seeing in premenopausal patients. I already mentioned that the minority of patients underwent ovarian function suppression. We did not capture the rate of having pathologically or clinically node-positive breast cancer prior to surgery. And some subgroups are not overwhelmingly represented in responder. For instance, most of the patients had one node, less than 10% had 3 nodes, less than 6% had T3 tumors or greater, and 5% of patients were non-Hispanic Black. So to address the question about whether the benefit is being driven by chemotherapy or not, NRG has a study that is now CTEP approved that should be hopefully opening in clinics within the next year, which is looking at premenopausal women with hormone receptor positive HER2 negative breast cancer, includes patients with 1 to 3 nodes involved with recurrence score 0 to 25, the population we just talked about from responder, as well as the TAILOR-X population that we talked about, who have a recurrence score 16 to 20, node negative, high clinical risk, and recurrence score 21 to 25, where they are randomized to receive ovarian function suppression and aromatase inhibition versus doing that plus chemotherapy, to really ask the question about chemotherapy benefit. And this study will be about 4,000 patients. And this will be a very important study. So we spent a lot of time talking about the Oncotype DX recurrence score. Just highlight there are other genomic assays that exist. We'll spend some time talking about MammaPrint. There's also Prosigna, EndoPredict, and we'll talk just a little bit about Breast Cancer Index. The MINDAX study was a study that looked at the 70 gene assay, and this was a different design. This design looked at clinical risk and genomic risk. And if there was a discordance between those two, those patients were randomized. So that was the question that was being asked here. This study, which also was published in the New England Journal of Medicine, saw that for the primary endpoint, which was looking at clinical high risk, genomic low risk, who did not receive chemotherapy, in terms of the distant metastasis-free survival, this did not exceed the lower bound. So this primary endpoint was reached. And when you look at a secondary endpoint, those patients in this population, again, high clinical risk and low genomic risk, those patients who received chemotherapy is demonstrated in red versus those that did not receive chemotherapy. When you look at 8-year distant metastasis-free survival, there's a difference of about 2.6%, but again, you can see the confidence interval. The study was not powered to look at this analysis. This is an exploratory analysis. But when you look at these patients, again, high clinical risk, low genomic risk, and you look at age, those patients who are age 50 or less or age greater than 50, and you look at 8 years distant metastasis-free survival, it's really the young women who are driving this benefit. And what I would argue is that the results we're seeing across all of the studies, TAILOR-X, Responder, MINDACT, for those women who are less than or equal to 50 years of age or premenopausal, those are the patients, some of whom may be deriving benefit from getting chemotherapy. It's worth highlighting that not all the genomic assays are the same. There have been some important data that have come out from the TransAtac study, which is the biomarker translational medicine component of the ATAC study, which was a study in postmenopausal women comparing different aromatase inhibitors. And you can see with the different gene signatures in the node negative and node positive populations, when you're looking at how they inform prognosis, they have different levels of C index, right? That the recurrence score in terms of its prognostic utility within years 5 to 10 is different than what we see with some of the other assays, for instance. And these were some other data that came out from TransAtac where it was shown that the recurrence score seems to be more strongly determined by its estrogen module than its proliferation module. But this also may be because the score, which I showed you at the beginning, can be, when you look at the proliferation module, that score is thresholded. So I've alluded to the breast cancer index, and this is just one slide, which shows a lot of data, years of data in just one slide. The breast cancer index is a different assay, which looks at around 11 genes and reports out H over I. And in these various studies, some of which are just some cohorts that were not randomized studies, but some, like for instance, they have some data from a Norwegian cohort. These are, so this particular assay is asking the question from years 5 to 10, right? So for patients who've done their 5 years of anti-estrogen therapy, is there a benefit for extending adjuvant hormonal therapy for another 5 years? Because there's some patients who benefit from doing 7 or 10 years compared to just doing 5. And when we utilize this assay, what this is showing us in red is those patients who have H/I high, these seem to be the patients who benefit from extending endocrine therapy, as opposed to those who are H/I low, who do not seem to be benefiting from extending adjuvant therapy. I'll also say there were some other studies, like some data from NACBP B42, which did not demonstrate the same sort of prognostication for H/I, or rather predictive ability of H/I. But it's also important to know that that study had very few distant events and was primarily having local regional events. So I just want to conclude this talk by giving a sense of where I think things are going. One of the things we know about this subtype of breast cancer is that the risk for patients with hormone receptor positive, HER2 negative breast cancer isn't just within the first 5 years. There's a risk that happens years out. And even for our patients with no negative disease, this risk can continue. And what we've seen with other studies, which extend endocrine therapies, when you do extend endocrine therapy, it's not so much decreasing the likelihood of a distant event, rather a local regional event. There have been a number of prospective retrospective studies that have looked at the potential utility of circulating tumor DNA as well as CTCs. This is just one set study. Of course, there are some differences between the assays, some differences between the ctDNA platforms, but similar to our colleagues in other tumor types, including colorectal, there are prospective studies that are being conducted that are asking the question not just about the prognostic utility of, for instance, circulating tumor DNA, but the predictive ability as well. And we have a study for patients with triple negative breast cancer that Manali Bobby and myself are leading, which will be a national study, which is going to be asking the question for patients with triple negative breast cancer, whether CT, if you change the systemic therapy for those patients who are ctDNA positive, whether that can decrease the likelihood of recurrence. So very much, I think that this is really going to be at the forefront of where the field is going. So to conclude, hopefully I demonstrated that there's been significant progress in identifying who can opt out of chemotherapy. In premenopausal women, we still have some ways to go for identifying strategies for de-escalation. And I mentioned the NRG study, which will help us answer the question about ovarian function suppression, or whether patients still need chemotherapy. And we spent a little bit of time just talking about late recurrence, and that there could very much be a role for circulating markers, and there are studies that are ongoing which will help define that. I appreciate everybody's time and attention, and I look forward to any questions that anybody may have.
Thank you, Dr. Kalinsky. That was a wonderful presentation. Impressive work. If there are any questions, please use the chat function, or the Q&A function, I should say, to enter those questions. While we wait on questions, I wanted to mention that next week there will be no grand rounds. To view all upcoming Winship Grand Rounds lectures, please visit the Grand Rounds page on the Winship Cancer Center website or the Winship calendar. So there is a question from Dr. Hanasoge. She asks, what are your thoughts about patients with 1 to 3 nodes, but they have extracapsular extension in the context of our exponder? I think she's referring to the postmenopausal patients.
Yeah, so in the supplement of the paper, in the forest plot, we include extranodal extension for both premenopausal and postmenopausal patients. And if you look at the postmenopausal population, again, this is an exploratory analysis, and you look at extranodal extension, chemotherapy still did not seem to be, for that subgroup who had extranodal extension, that was not a predictor for benefit for chemotherapy. So that is demonstrated in the supplement of the paper.
Thank you. Dr. Langston asks, where does inherited susceptibility fit into the decision equation?
Right. So there have been some smaller series that have looked at oncotype scores in the context of having BRCA mutations. What I will say in clinical practice, where we utilize or when we determine therapy based upon the presence or absence of a BRCA mutation, for instance, for patients with hormone receptor positive, HER2 negative breast cancer, we rely on data from this randomized study called the Olympia study, which for those patients, the study was published in the New England Journal of Medicine and ESMO from an ESMO virtual about a month ago. It was demonstrated that those patients had hormone receptor positive, HER2 negative breast cancer who had high risk disease. For instance, they got chemotherapy before they went to surgery and they have a lot of residual disease. Patients benefited from giving a year of olaparib, the PARP inhibitor. And that study also included patients with triple negative breast cancer. So the same holds true. Let's say you have a patient who gets neoadjuvant chemotherapy and then they go to surgery and they have significant residual disease. We see that patients have a benefit not only for preventing distant recurrences, but also an improvement of overall survival if they get a year of PARP inhibition. And for us, this has only increased the amount of genetic testing that we should be doing for our patients. And we have studies that are ongoing here, including a study that Dr. Jones in our group is doing. Dr. Torres is looking into this as well, which is also looking at, well, what is the rate of genetic testing within our population? And are there any differences, even differences that we're seeing based upon race and ethnicity in terms of how much genetic testing we're doing for our patients? Because now there's some clinical implications for this.
Okay. Dr. Janipal Naylor says, great talk. What are your thoughts on sequencing APBI? I think he's referring to accelerated partial breast irradiation first, while waiting for the genomic score to result.
Yeah, I think we of course defer the specific type of radiation therapy from our radiation colleagues. Generally, we tend to, if patients have a high score and need chemotherapy, we tend to do chemotherapy first and then follow that with radiation and then hormonal therapy. That tends to be the standard. But I think that of course it's a conversation between radiation oncology and medical oncology, but that does tend to be the sequencing that we've historically been utilizing.
I think he might be asking about the relationship between the genomic score and risk of local recurrence. I'm not sure, just reading between the lines of his question.
Yeah, the other thing I will say, and I can speak for the node positive population, we haven't in Responder reported out the radiation utilization. And this isn't what's being asked in this question, but also we're going to report out the rate of, for instance, post-mastectomy radiation and the outcomes. And so that has been submitted as an abstract to a Congress. And hopefully those data will be reported this year from Responder.
Okay. All right. Any other questions? Okay. Well, thank you so much, Dr. Kalinsky, for your presentation today. It was wonderful. And everyone have a great day and a great week. Oh, is there one more? Okay, one more question, sorry. Dr. Janipal Naylor is just thinking if you can do a 5-fraction regimen for someone who may or may not need chemo, NCCN now allows conditional recommendation for radiation before chemo. Do you want me to take that one, or do you want? Okay. So what I would say is, if the patient has a high genomic score, that is not a patient that you would do APBI on, because that's, someone you wouldn't give because they're in the context, they're going to be receiving chemotherapy. So doing APBI or 5-fraction regimen prior to having all the information, it's okay if the score comes back low, because that's an option you would have given the patient regardless. But if the score were to come back high or high intermediate, that's not someone that we would offer APBI to, generally speaking, because recurrent score is related to local regional risk in a lot of different studies. And I imagine that's going to be the case when this abstract comes out that Dr. Kalinsky is referencing. But that's what I would say about that.
I'll also say two things. One, I think even this conversation is demonstrating how multidisciplinary the care is for our patients with breast cancer. The other thing I'll say is that there are studies that are going on with the cooperative group that's looking at the role of radiation in the context of the recurrent score. And those are some studies that we will be opening here as well.
Okay. Well, thank you. And everyone have a wonderful day. And thank you, Dr. Kalinsky, again for a fantastic presentation.
Thank you.
Right.
Thank you.